The following podcast is part of a certified educational activity titled 3 R's for Modern Myeloma Care, Delivering the Right Treatment for the Right Patient at the Right Time with Antibody and BCMA platforms. Access the entire activity and complete the post-test at peerview.com/VRK860. Downloadable slides and practice aids are also available.
All right. Thank you all for coming tonight. And for our program, the 3 R's for Modern Myeloma Care, delivering the right treatment for the right patient at the right time with Antibody and BCMA platforms. I'm joined here by my colleagues, Dr. Jonathan Kaufman, Dr. Noah Baran, and I am substituting for Dr. Robert Orlowski tonight. My name is Pete Voorhees. So again, thank you all for coming tonight. So just a timeline of progress with monoclonal antibodies, bispecific antibodies, and CAR T-cell therapy in myeloma. So as many of you know, single-agent daratumumab was first regulatory approved back in 2015. Elotuzumab, the SLAM-F7 monoclonal antibody, was approved in combination with lenalidomide and dexamethasone for patients with relapsed myeloma having received 1 to 3 prior lines of therapy. Move forward to 2020. Daratumumab is now approved in many different combination settings, including subcutaneous dosing, moving from intravenous. Isatuximab is approved, the other CD38 monoclonal antibody, for the first time in combination with pomalidomide and dexamethasone. We move to 2021, where we have more CD38 antibody combinations getting approved, and the first BCMA antibody expanded indications for isatuximab, specifically in combination with carfilzomib and dexamethasone. And belantamab mafodotin, the BCMA-directed antibody drug conjugate, got an accelerated approval at that point, which was subsequently rescinded. But as we'll see at ASCO this year, the DREAM7 and DREAM8 studies, which were presented earlier today and will be presented tomorrow morning, will certainly change that landscape. Moving to 2021 and 2022, we have the first approvals of BCMA-directed CAR T-cell therapy. First, ide-cel, secondly, cilta-cel, but only in patients who've had 4 or more prior lines of therapy. Fast forward to 2022, 2023, and we have the first approval for BCMA and GPRC5D-directed bispecific antibodies, specifically teclistamab, elranatamab, and talquetamab. And now, in 2024, we now have a new indication for our CAR T-cell therapies. Ide-cel is now available for folks who've had 2 or more prior lines of therapy, and cilta-cel is approved for patients who've had 1 or more prior lines of therapy. So despite this incredible progress over the last several years, it seems that there's underutilization of some of these assets, not only in the frontline setting, but in the relapsed setting as well. This is the Insight Multiple Myeloma program here, and what you can see here, perhaps shockingly, although I think that this is rapidly changing, in the frontline setting, you only have 2% of patients receiving monoclonal antibody therapy, CD38 antibody-based therapy, and then you move into the second line, and it's only 14%. So we certainly need to be doing better and adopting these very powerful therapies sooner. So this is a real-world outcomes, and it just kind of highlights the need for new therapies in the triple-class refractory and even the triple-class exposed and penta-exposed patients. So this is a Medicare and Medicaid claims database from 2006 to 2020, and we're looking at time to discontinuation of therapy and time to next treatment. With the Medicare, Medicaid claims database, you can't really look at progression-free survival, so these are kind of surrogates for progression-free survival, and you can look at overall survival as well. And as you can see here on the right-hand side of the slide, for those patients who have triple-class refractory disease, their time to discontinuing therapy is very short because of poor progression-free survival, thus the need for new, more powerful regimens in that particular space. So the goals for today are, 1, to improve your understanding of evidence supporting CD38 and BCMA targeting antibodies and CAR T-cell therapy in different myeloma treatment settings. 2, to equip you with the skills you need to develop personalized upfront and sequential treatment plans with antibody and immunotherapy platforms. and 3, help you develop strategies to address practical dosing safety and patient education considerations when using antibody and BCMA platforms in multiple myeloma. So moving on to the HealthTree Foundation for multiple myeloma. They offer resources for patients to tell their stories and contribute to scientific research in the form of the HealthTree Cure Hub and HealthTree Research Hub. So this is a patient data hub and a companion research hub that power kind of life-saving research using complete real-world data. So specifically, patients who elect to contribute to this program basically provide their data into the HealthTree Cure Hub with the help of the HealthTree crew. So everything about your myeloma, baseline characteristics, treatment history, drug class refractoriness, et cetera, everything is extracted from your medical record in a HIPAA-compliant manner. There are also survey-based initiatives that investigators can do for patients and conduct other kind of important retrospective research. A really powerful platform for those patients that are listening to us online. Strongly encourage you to take part in this initiative. So researchers can access the data, so folks like us can access this data through data mining, chart reviews, synthetic control arms. They can also invite patients, as I said before, to complete surveys and studies, et cetera. So 76 studies and surveys have already been conducted, 65,000 total number of study participants. This is a large percentage of living myeloma patients in the United States. 14,000 HealthTree Cure Hub users, and we'd like that number to continue to grow. Very fast turnaround time. They're a very efficient machine. 9 to 18 months average time to completion, and 4 to 6 weeks average time to recruiting patients. So really, again, a very powerful mechanism, and one I would encourage patients to participate in and researchers to utilize. So with that, we're going to start with CD38 antibody-based therapy for newly diagnosed myeloma patients, and we're going to start off with 2 patients. So the first one on the left is Jane. This is a woman aged 63 years presenting with revised ISS stage 3 myeloma, so high risk, performance status of 1, no major comorbidities, and she has 2 high-risk cytogenetic abnormalities, a 414 translocation and amplification of 1q21. That means she has at least 2 extra copies of 1q21. In contrast with Michael on the right, who's a man age 74 presenting with revised ISS stage 2 newly diagnosed myeloma. Michael has a performance status of 2. He has comorbidities of type 2 diabetes, hypertension, congestive heart failure, GERD, and by FISH, the patient has hyperdiploid disease. So with that, let's move on to the discussion, and we're first going to focus on Jane. So, to my colleagues here, what is the current standard of care for this patient, a triplet or a CD38 quad? And I'll start on the end there with Jonathan.
So this patient, as you described, has high-risk myeloma and clearly needs treatment. We were fortunate enough to participate on the Griffin study, which in a phase 2 manner compared the 4-drug regimen of DARA RVD versus RVD. And that study showed that it was safe to give, that there was associated with an improvement in deep responses, that was associated with, and now we see an improvement in progression-free survival. And then subsequently was the phase 3 study with Perseus, which showed the same thing, but really was a much larger study and really locked in the improvement in progression-free survival. And so from my perspective, I think it's pretty standard that I would give this patient a 4-drug regimen that include daratumumab plus RVD. So I guess we'll just do the top question first.
Yeah, and just kind of following up on that, Noah, do you have strong feelings about what proteasome inhibitor is used in a quadruplet in the frontline setting for a high-risk patient?
I would absolutely choose carfilzomib as my proteasome inhibitor of choice for this patient. I think for many reasons, the most important is toxicity. I think with bortezomib, you can have peripheral neuropathy, which can be quite unexpected. It usually occurs it can occur even with one dose. It usually takes a few cycles before you develop peripheral neuropathy, and it can be irreversible in about 2/3 of patients who develop peripheral neuropathy. So for one reason, toxicity, but I think carfilzomib has excellent activity and it would argue is much more potent compared to bortezomib, especially in high-risk patients.
Very good. Jonathan, I think I know how you're going to answer this question, but should autologous stem cell transplantation always be considered after induction therapy?
So in this particular patient with high-risk disease, we would always recommend moving with high-dose therapy. The most recent study that looked at early transplant versus not was the determination study. And if you look at the progression-free survival in that study in the high-risk patient population with transplant was 55 months versus 17 months for the non-transplant. So I think in my mind, it's still a very easy decision in an otherwise healthy patient who I consider young with myeloma to move forward with early autologous transplant after induction.
Very good. No, any additional thoughts?
Yeah, I agree. I think that certainly in high risk, and I think if we're doing something in the high risk subset, we should do that in everybody, because at the end of the day, even our standard risk patients need all the treatments they can get until we have an absolute cure of the disease. Yes, we can have functional cure, but all the treatments are additive in nature, so I would not deny a standard risk patient one of the most effective therapies that we have.
I'm in 100% agreement.
Very good. I think Jonathan did a nice job kind of outlining the experience with quads and patients suitable for transplant, when he answered the first question. So I'm going to move on to MRD. So is achieving MRD negativity with a quadruplet an appropriate goal of therapy? And Noah, I'm going to start with you, but I'm going to ask you both this question.
Absolutely. I think we've established across many prospective trials that MRD negativity, either by next generation sequencing, which is sensitivity of 10 to the -6, or multi-parametric flow cytometry with the sensitivity of 10 to the -5, although much less standardized, correlates with prognosis. It correlates with durability of response, PFS, and OS in some studies. I think there is a caveat to MRD negativity in a subset of patients who are high risk, where they do achieve rapid MRD negativity and progress much more rapidly, even 3 months, after achieving MRD negativity. So we have to be careful. We also have to frame it in context to our patients. But I think now it is going to be an acceptable endpoint for clinical studies moving forward.
Jonathan?
So is achieving MRD negativity an appropriate goal? And I think it is an appropriate goal, but this is a very important point, is that we should choose the regimen that has the greatest chance for a population to get to MRD negativity, but we don't necessarily target MRD negativity for a specific patient. And for a handful of reasons. One, just like the high-risk patient who has MRD negativity and then rapid progression, we also have, and it's still true to this day, those patients with a long history of MGUS. Some of those patients never achieve a CR. And so, the patient who gets MRD negativity with induction therapy is going to, a group of patients who has MRD negativity with induction therapy is going to have better long-term outcomes than a patient who requires 3 different induction therapies to get to MRD negativity. So I think that's what it's really important to me when we talk about MRD negativity, choosing the regimen that has the greatest likelihood of MRD negativity.
Yeah, I agree with Jonathan 100%. We don't have the randomized trials yet that tell us whether we can escalate therapy to change the outcome for somebody who's persistently MRD positive after initial planned course of therapy. And similarly, we don't have randomized data supporting de-escalation of therapy if we've managed to achieve MRD negativity or sustained MRD negativity. Those studies are enrolling patients as we speak, so we will have those answers for you. But for now, we don't.
Yes.
So let's move on to Michael. So this is our 74-year-old with comorbidities. So Noah, let's start with you. What is the current standard of care for this patient, a triplet or a CD38 quad?
So that depends on your whether or not you consider this patient to be transplant eligible or ineligible. Certainly, comorbidities increase risk of mortality from an autologous stem cell transplant, and I would argue that those comorbidities increase morbidity and mortality from chemotherapy, from prolonged chronic chemotherapy. So it's very physician-dependent, institution-dependent on whether or not this patient would be a transplant candidate. In our institution, we would probably transplant this patient. So I would probably do either a quad, Dara-VRd, or if he had a normal ejection fraction and controlled hypertension, KRD, followed by an autologous stem cell transplant.
Jonathan?
Yeah, I think this case would be easier for me to answer if the patient was 76 or 77. So I probably, and I think Noah is exactly right. This is, if you go with different institutions are going to treat differently, even within the same institution, you might get different answers. I probably would lean to not transplanting this patient. And, we're waiting on all of the data to come out in the non-transplant patient of the 4 versus 3 this weekend here at ASCO. I probably would give this patient a triplet with, right now, Dara-Lendex. It would be my triplet of choice for this patient. And I would be very concerned that I would do harm to this patient if I gave standard 4-drug therapy followed by an auto transplant. The other comment I would make about performance status is the question is this patient's performance status that of 2 because he's sick from myeloma, and as soon as he's no longer sick from myeloma, he's going to look like a different person, or 6 months ago was his performance status 2 and he has myeloma, and that would help me also make a decision for the patient.
Yeah, the devil's in the details, the severity of the congestive heart failure, for example, which gives me pause about using a quadruplet. In this particular patient, I might avoid the proteasome inhibitor in that particular case, and if the patient's performance status is 2 because of these comorbid illnesses that we've outlined here, then I probably would veer against a transplant in this patient as well. I think the second question I will address, through my talk. So let's move on to the next question. Noah, in this particular case, could you modify quad dosing, to my point about the congestive heart failure, to ensure safe delivery of therapy?
Absolutely. Quad, if you're going to use bortezomib, you would use I would use a once-weekly dosing, probably 1.3 milligram per meter square, reduce the dose of dexamethasone, taper it as quickly as possible, and be very careful with the IMiD in terms of cytopenias, renal dysfunction, and dose it appropriately, and be proactive about monitoring for infections in a patient like this who's already at high risk of pulmonary and cardiac toxicity.
Very good. And I think for the sake of time, I'm going to move past this last bullet point about principles of using the CD38 in quads, whether it's RVD or KRD as the backbone, and hopefully I'll address that in the talk. But as far as recommendations for the transplant fit and unfit settings, so high-risk disease benefits from more aggressive induction, and we'll show you that data about the quads versus the triplets shortly. Adding stem cell transplant is very reasonable, particularly in a high-risk patient population. And achieving MRD negativity is an appropriate goal of a study. Using the regimen that gives you the best chances of getting to MRD negativity, to Jonathan's point, is the exact right thing to do, but we don't have randomized data yet on the appropriateness of escalating or de-escalating therapy based on that result. Going to the older patient, hyperdiploidy, so I failed to mention that 414 in a vacuum by itself with no other high-risk features is not necessarily that high risk in the era of proteasome inhibitors. That said, the patient case had an amplification of 1q21, so it was clearly high risk. Hyperdiploid is actually a much better risk patient population that does extremely well in this day and age. And then the triplet versus quad selections based on comorbidities, patient family goals, and logistical and economic factors as well. Achieving MRD negativity is nice, but not required for a good outcome. So what is the evidence supporting CD38 quads in transplant-fit patients? So these are the NCCN guidelines, and you can see here the preferred regimens are two triplets, actually, RVD and KRD. But as far as other recommended regimens, you've got daratumumab with RVD listed here. And then there are other quad options listed here as well, including dara-VTD and dara-KRD and Isa-RVD in certain circumstances, recognizing that these recommendations are going to change very soon. So Griffin was a randomized phase 2 trial that added daratumumab to the standard RVD backbone in transplant-eligible patients. And what we showed in this particular study is that patients on the 4-drug arm achieved deeper responses, such that by the final analysis, the vast majority of patients were in complete response or better. And this was clearly superior to the triplet group. And this translated to improved progression-free survival. So at the 4-year mark, 87% of the patients in the quadruplet arm are alive and free of disease progression versus 70% for those that were assigned to the triplet, yielding a hazard ratio of 0.45. So this was a randomized phase 2 study because we wanted to get it in the NCCN guidelines for utilization in the United States, because at the time that Griffin was designed, RVD was not a platform for a registrational study. But SWOG S0777 completely changed all of that calculus, and that led to the birth of Perseus, which was a phase 3 study looking at the addition of daratumumab to the VRD backbone in the same patient population, transplant-eligible patients. So patients received 4 cycles of induction therapy with the quad or the triplet. They went on to a single stem cell transplant. They received 2 cycles of either triplet or quadruplet consolidation therapy, and then went on to dara-len maintenance versus len maintenance. And the primary endpoint of this particular study was progression-free survival. So not surprisingly, the addition of daratumumab to the VRD backbone improved progression-free survival. And what I'll point out is that the PFS advantage is virtually identical to what we saw in the Griffin trial. So the hazard ratio here is very similar to what we saw in the Griffin study. And then if you look at the 4-year mark, 84.3% of patients in the quadruplet arm are alive and free of disease progression, in contrast to 67.7% for those that received the triplet, yielding a hazard ratio of 0.42 in contrast to the 0.45 in the Griffin study. Now, when you look at the forest plots here, what you can see is that the quadruplet outperformed the triplet even in patients with high-risk disease. So specifically those patients who had ISS stage 3 disease, as well as patients who had high-risk cytogenetic abnormalities. There's this fallacy that you hear periodically that CD38 antibodies don't work in high-risk disease, but that's really not the case. And I think that this is an excellent example that refutes that supposition. So looking at MRD negativity over the course of time. So I'm going to focus on the right here at 10 to the minus 6. So if you look at 12 months into maintenance therapy, 44% MRD negative at 10 to the minus 6 versus 21%. You go to 3 years into maintenance therapy and 64%, so nearly 2/3 of patients in the quadruplet arm have achieved MRD negativity at 10 to the minus 6, in contrast to just 30.8% for those that were assigned to the triplet. And this is going to be the subject of an oral abstract tomorrow. As far as safety, no surprises here. So we saw more high-grade neutropenia when we added the CD38 antibody to the VRD backbone, but otherwise toxicity was very similar between the 2 arms of the trial. So let's move on to ISKIA. So ISKIA was a study that looked at newly diagnosed, fitter, transplant-eligible patients with newly diagnosed myeloma and assigned them to either KRD or KRD with the CD38 antibody isatuximab. So patients got 4 cycles of induction therapy with the quadruplet or the triplet. They went on to a single stem cell transplant. They got 4 cycles of post-transplant consolidation with either the quadruplet or the triplet. And then they went on to a light consolidation, 12 cycles of therapy, either with a triplet or a doublet in the two arms, a quadruplet or a triplet, in this particular study. And they were looking at MRD status at the end of induction, after transplant, after the first transplant consolidation, and after the light consolidation. So these are the results, and I want to focus on the right-hand side again. I think MRD negativity at 10 to the minus 6 is a much better differentiator of efficacy of these regimens. And you can see in the quadruplet arm, 67% of patients, at the end of consolidation had achieved MRD negativity at 10 to the minus 6, in contrast to just 48% for those that received KRD, which is a good result. But clearly the addition of the isatuximab significantly improved achievement of MRD negativity in this group of patients. And then again, looking at the forest plots here, and specifically looking at MRD negativity at 10 to the minus 6, you can see here that the MRD negative status is clearly improved for patients with high-risk cytogenetics, and including patients who have one high-risk cytogenetic abnormality, as well as those who have two or more high-risk cytogenetic abnormalities, and whether you have revised ISS stage 1 or 2-3 disease, or the new R-squared ISS staging system. So regardless of stage or cytogenetic risk, you were more likely to achieve MRD negativity with the Isa-KRd quad. Again, from a toxicity perspective, more high-grade neutropenia when you add a CD38 antibody to the KRD backbone, as shown here. But otherwise, the toxicity profiles, including the infection toxicity profiles in this particular study, were very similar between the two arms of the trial. So isatuximab has also been combined with the RVD backbone in the GMMG HD7 study. So this is a trial, again, in transplant-eligible patients, looking at whether isatuximab added to RVD would improve MRD negativity. And as you can see here, after 18 weeks of induction therapy with the quadruplet, 50% of patients were MRD negative at 10 to the minus 5, in contrast to just 35.6% of those patients that were assigned to the triplet. And not surprisingly, depth of response measured by conventional means was also superior. So let's go ahead and move on to folks who are not eligible for upfront transplant. And again here, we're going back to the NCCN guidelines, and you can see here that CD38 antibody-based triplets and quadruplets are actually included in the NCCN guidelines for transplant ineligible patients. So preferred regimens include what we're all familiar with, VRd, but we also have daratumumab, lenalidomide, and dexamethasone. That's another category 1 regimen. We have the Alcyone data that yielded daratumumab with bortezomib, melphalan, and prednisone. That's not used in the United States that much these days. And there's another quadruplet that can be considered in certain circumstances, specifically daratumumab with CyBorD. So MAIA is a study that I think many people are familiar with at this point. This was a phase 3 study that looked at the addition of daratumumab to the lenalidomide dexamethasone backbone for newly diagnosed myeloma patients who are not transplant eligible. I will point out that the median age in this study was much higher than the typical phase 3 study that we see in the frontline setting. And as you can see here, the median progression-free survival was really quite remarkable with the addition of daratumumab, specifically almost 62 months, in contrast to 34.5 months for those that got the len-dex doublet, yielding a hazard ratio of 0.55. But more importantly, median overall survival was improved as well. So the hazard ratio for overall survival was 0.66, so you're looking at a 34% reduction in the risk of death from any cause with the addition of daratumumab to the RD backbone. This is data from the Alcyone study. This was a trial that looked at bortezomib, melphalan, and prednisone with or without daratumumab. And with very long follow-up, totaling almost 80 months, you can see this dramatic improvement in progression-free survival with this particular old-school quadruplet relative to the triplet. And if you look 6 years out, you can see that the progression-free survival is about 32% for those that got the quad versus only 7% for those that got the triplet. So I'm now going to move on to the IMROZ trial design. So this is a study that's going to be presented in the oral session at the Myeloma oral abstract session tomorrow, and I very strongly encourage you all to attend that session. So this is a phase 3 study looking at the addition of isa-tuximab to the RVD backbone for patients that are not considered eligible for stem cell transplantation. 440 patient study, assigned 3 to 2 to the experimental versus control arms. Patients received 24 weeks of induction therapy with either the quadruplet or the triplet, and then they went on to continue either Isa-RD or RD until progression or the emergence of unacceptable toxicities. And interestingly, there was a crossover in the control arm for those patients progressing. Primary endpoint was progression-free survival. This is the dosing schedule for the agents. I'm not going to belabor this point, but I will point out that the frequency of isa-tuximab does reduce over the course of time to the point where it's actually only given once every 4 weeks in the continuous dosing setting. So the primary endpoint of the study was met. This was the subject of a press release during the ASH meeting back in December, showing that the addition of ISA improves progression-free survival when given to transplant-ineligible patients receiving the VRd backbone. So specifically, there was a 40.4% reduction in the risk of progression or death with the addition of isa-tuximab to the VRd backbone, and this PFS benefit was consistent across subgroups. We'll have to see the presentation tomorrow again to learn more about that, and actually maintained through the next line of therapy, so progression-free survival too. So time from a diagnosis to the time of the second progression was still improved for those patients that received the quadruplet. So IFM 2020-05, or the benefit trial, is a really neat study. You know, a lot of us were very swayed by the Maya data with daratumumab RD in the transplant-ineligible patient population. So a lot of us are like, well, do we really need to use these quadruplets? Can we just use a CD38 antibody with len-dex for this particular patient population? So this is a randomized study that's looking at isa-tuximab, len-dex, with or without the addition of weekly bortezomib. So this is a real-world study, which I think is incredibly important. And we don't have longitudinal follow-up in this particular trial, but what you can see here in the table down at the bottom here is that there were more patients who achieved a complete response or better, 40% versus 18% for the quadruplet. There were more patients who were in complete response and MRD negative, 21 versus 12%. And when you look at MRD negativity at 10 to the minus 6, 34% versus 15%, and all of that was statistically significant. And obviously we'll need longer follow-up to make any meaningful conclusions about whether that translates into improvement in progression-free or overall survival, but there's not a single randomized trial with a CD38 antibody where a PFS advantage was not seen. So it's, but again, the variable here is bortezomib, so it'll be very interesting to see how that plays out. The Cepheus trial is very similar in design to the IMROZ study, but the CD38 antibody of this particular study is daratumumab as opposed to isa-tuximab, and we expect that this will probably report out sometime in the near future as well, so we very much look forward to that particular data set. So moving on to the Emory data set from Jonathan and others in his group. So this is data from the Emory myeloma program looking at Dara-RVD-based therapy for newly diagnosed patients. The Emory crew was quite bold and adopted quadruplets as their standard of care at their institution after we had published the 16-patient safety run-in of the Griffin trial. So they've got way more patients than any of us who've received these quadruplets.
You showed it was safe. And we believed it was effective.
So, but I mean, their early experience, as you can see here, looking at progression-free survival, you know, whether you're standard risk or high-risk patient, does, you know, favor the quadruplet over the triplet in the real-world setting. And actually, I mean, again, it's early days, but their curves look very similar to what we reported in both Griffin and Perseus. And it'll be very interesting to see how overall survival plays out over the course of time. But I think, you know, this suggests, you know, that the quadruplets with CD38 antibodies are performing well in the real-world scenario. So as far as principles for safe delivery of CD38 antibody therapy, I think many of you know this, but appropriate HSV, zoster reactivation prophylaxis with acyclovir or of its equivalent, appropriate pre-medications, at least for those first couple of doses. You can scale back afterwards. Pre-therapy blood screening, getting that type and screen. The daratumumab is going to make that direct antiglobulin test become abnormal. Screen for hepatitis B because reactivation does occur with the use of CD38 antibodies, and those patients at risk of reactivation will need prophylaxis such as entecavir, for example. Sub-Q versus intravenous administration, there is an observation period required after the first dose that I suspect is institutional dependent. And then, treat infections aggressively. We know that CD38 antibodies cause hypogammaglobulinemia, and you need to be proactive about infection management and vaccination. So one last thing, isatuximab is emerging as a sub-Q formulation. So Sanofi is actively in the process of studying an on-body subcutaneous delivery system for administration of isatuximab subcutaneously, and they are doing this in the context of a randomized study against IV isatuximab in combination with Pomdex. So with that, I'm going to hand off to Noah, who's going to talk to us about early relapse therapy with antibody platforms and BCMA-directed CAR-T.
Thank you. So a year ago, we wouldn't even be mentioning CAR-T as a part of an early relapse conversation, but we're fortunate in that we have opportunity to use these therapies much earlier on in the lines of therapy. And just to refresh everybody's memory, the philosophy of treatment for multiple myeloma, because it is a chronic disease, is use your best therapies early. And it is a very heterogeneous disease, and it changes with each relapse. So we'll start with a case. Brian is a man age 63 with IgG kappa myeloma, presented with vertebral compression fractures and anemia. Dury Salmon 3A, International Staging System 2, revised ISS stage 3. 1q21 gain by FISH and a 13q deletion, normal cytogenetics, and he has a DNMT3A mutation by next generation sequencing. So he was treated with VRD, followed by a stem cell transplant, achieved a CRD, MRD negative, went on len maintenance, and after 2.5 years, he stopped the lenalidomide. So 3 years following transplant, he has a rising free kappa and an M spike and a new fracture. What are we going to do with this patient for early relapse? So to summarize, he's relapsed 3 years after transplant, 2 years of len maintenance, and now rising free kappa with symptomatic relapse, a fracture. So we can talk about one or two different scenarios. So one would be if this patient was actually progressing while on lenalidomide. What would you determine? 3 years after auto with len maintenance, would you consider this to be an early relapse, first of all?
Yeah, so I mean, and when you look at the data, 3 years or 2.5 years into maintenance therapy is an early relapse, so this would be considered a functionally high-risk patient. So I think CAR T-cell therapy, specifically cilta-cel, which is now FDA approved in first relapse for patients who are lenalidomide refractory, is on the table. And with regards to the first question here, would I treat this patient with a CD38 triplet? Absolutely, but not to defer CAR T, but as my therapy strategy to control their disease as I'm getting ready for apheresis to manufacture those CAR T cells, use that CD38 regimen during the manufacturing process.
What about you?
Yeah, I completely agree. And I think if one of the first questions we asked, it says, should all patients get bridging therapy? And I think the studies that led to the approval, I think, have taught us quite a bit. And we've all suspected this for a while, but I think the CARTITUDE-4, we're going to see the data shortly, is that CAR T-cell really should be used as consolidation for effective therapy in the relapse setting. And that's what that study really showed. And so 100% agree, this patient needs to get back into have a response, have disease controlled, then have CAR T cells collected, then stay on therapy for however long the manufacturing takes, and then have CAR T cells. So that's exactly how I manage this patient. And 3 years is sort of right on that borderline of is it high risk? Is this a functional high risk or not? But I think we're going to see data here at the meeting looking at CARTITUDE-4, and in those patients who have the very short PFS after induction with 18 months, absolutely benefit from this approach. So yeah, not right to transplant not right to CAR T cell without therapy, but similarly to how do we treat transplant as consolidation. I think that's how that's how we should think about CAR T cell.
Yeah. The one thing I would say here, as we're thinking about CAR T cell therapy, the vignette described the DNMT3A mutation. So I think it would be imperative that we repeat a bone marrow examination for this particular patient to see if the burden of that mutation has increased, if there's new mutations that have arisen, if there's any dysplastic changes, just out of the concerns about, a slightly increased risk of MDS-AML for patients undergoing CAR T-cell therapy. Now the risk seems to be much more prevalent in the heavily pretreated patients than in the randomized studies where it was utilized earlier, so the risk does seem to be lower in less heavily pretreated patients, which is what we would expect, but certainly something that we'd have to be cognizant of.
Yeah, I mean, I think that I had this exact conversation with a patient 2 days ago, actually a patient who's treated by one of your partners. And clearly if the patient has myelodysplastic syndrome on the marrow, I probably don't want to give fludarabine and cyclophosphamide and so forth, and then the CAR T cell. But the discussion I have, if somebody they might have MDS in the future abnormalities, is that myeloma is problem number one.
Right, exactly.
And especially if a patient has a relatively short progression-free survival after an auto transplant, I still think myeloma is the number one problem, and that's how I view it.
I agree with you. I think there's a lot to consider when you're deciding on CAR T cell as early relapse for a patient. Certainly we have proven treatments that are long-standing and have excellent PFS and durability. I think in a high-risk patient, we do have to discuss the risk of small risk of secondary possible malignancies with the patients and reevaluate concerning CHIP-like mutations. But I would agree that in a functionally high risk, it would be appropriate to debulk the disease with a CD38 triplet and then start the process for CAR T. And as both of you know, it can take a long time to obtain authorization from insurances, to schedule apheresis slots, and then manufacturing time, although it is shortening, can take up to 8 weeks. And you want to have a low burden of disease so that your patient can go into CAR T cells with a low burden of disease. So I think we discussed a lot of these points. Would you consider cellular therapies? What about patients who have extramedullary disease? Would you still consider them for CAR T cells?
Yes, so absolutely. I think, the challenge that we have for patients with extramedullary myeloma, so this is myeloma that's outside of the bone marrow compartment. They have high-risk disease biology. They typically relapse much faster with standard therapy, with bispecific antibody therapy as well, at least when used as single agents. The data with extramedullary myeloma and CAR T-cell therapy looks better than what we've seen with standard treatment. That said, they are not going to enjoy as durable of a remission as a standard myeloma patient going through CAR T-cell therapy, but I think if they did have extramedullary disease or other high-risk disease biology, that would just strengthen my decision more to go the CAR T-cell route.
And I'm going to ask Jonathan this question. If you can tell your referring physicians when they should refer to you for CAR T cells, when is the right time to do that?
Yes. I think it's early. I mean, I think if they have a patient who has relapse disease and they've initiated second-line therapy, as soon as the patient's responding, that's and as soon as the patient's responding, if they've started on second-line therapy and they're a year into it, a year and a half into it, it makes a little bit less sense to use CAR T-cell in that situation. Or if they're already progressing after second-line therapy, we're back sort of the drawing board, and we have to do a third-line therapy to get them back into a response. So I say as soon as the patient's responding.
I think that's a great way to say it. I think that's great advice. As soon as you have a response, start the process. So Brian is a man of 63 years who had early relapse after a triplet, transplant, and len maintenance. So the take-home points from this case are early referral for CAR T. High-risk feature especially should be considered for CAR T. And the indication for approval for cilta-cel is patients who've had one prior line of therapy who are len refractory. And we know with many studies and real-world data that CAR T cells are more effective when there is a lower burden of disease, and there's also much less risk of CRS when there's low-burden disease. So I would certainly start a CD38 regimen on this patient and then refer for CAR T. So CAR T cells are a fairly involved process, and it starts with leukapheresis of the patient's autologous T cells. Those cells are later manufactured through isolation and a viral vector to express the chimeric antigen receptor against BCMA, which is a protein on the surface of both malignant and healthy plasma cells. Those cells are expanded in vitro, and then once they are ready to go, they are infused into the patient. It can take, in some cases, 48 hours in some of the studies that are going to be shown here. But for the commercially approved CAR T cells, we have a wait time around 4 weeks to 6 to 8 weeks even. And in that period of time, the patient has to be on some type of bridging therapy to prevent rapid disease proliferation and controlling of disease. Once those cells are ready, they are reinfused into the patient, and the patient is admitted to the hospital for monitoring of symptoms, predominantly cytokine release syndromes. As those T cells expand and proliferate, they recruit other T cells in the vicinity and induce cytokine storm. So we have 2 FDA-approved CAR T-cell constructs. One is ide-cel. It's currently approved for patients with relapsed refractory myeloma after 2 or more prior lines of therapy, including an IMiD, a PI, and a CD38 monoclonal antibody. Cilta-cel is approved for relapsed refractory patients who have received 1 or more prior lines, so in second line, and must have had a PI and an IMiD and are len refractory. And here you can see the ide-cel structure involves a 4-1BB signaling domain, and the cilta-cel structure, which involves 2 binding domains. So this shows us the NCCN guidelines. You can see that both of the CAR T cells are included in patients with 1 to 3 prior lines of therapy under preferred regimens, category 1. So these are right under the other standard of care triplets with monoclonal proteasome inhibitor and IMiD-based therapies, as well as selinexor and elotuzumab-based therapies. CARTITUDE-4 was the randomized trial that evaluated cilta-cel in patients who had 1 to 3 prior lines of therapy and who were len refractory. So you can see here that median PFS was not reached in the cilta-cel group versus 11.8 months in the standard of care group. And the standard of care regimens, as well as the bridging regimens that were used in cilta-cel, were dara-pom-dex and pomalidomide-bortezomib-dex. And you see here the lowest hazard ratio that we have seen in the early relapse setting, 0.26. And you can see that cilta-cel, compared to standard of care, resulted in much deeper responses. Patients had not only deep remissions, but significant improvement in quality of life. And the reason is because time off therapy results in patients not having to come in every week, not having to have blood counts checked, and getting to really live as normal a life as possible. And I think once myeloma disease is controlled, patients' quality of life goes up in a meaningful way. So this is the abstract that was already spoken about in patients who have high-risk disease. This is a very difficult to treat population. And historically, patients who are double hit or have very high-risk disease have very poor outcomes, very poor progression-free survival, especially patients who have been exposed to the PIs, the IMiDs, and the monoclonal antibodies. And you can see that cilta-cel improved in this high-risk population, not only response rate, CR rates, MRD negativity, but PFS. And the more high risk they are, the more of a difference you see between the cilta-cel and the standard of care group. And you can even see a similar median progression-free survival in patients with standard risk and high-risk disease with cilta-cel. So cilta-cel may abrogate high-risk disease in myeloma, and that's very challenging to see. We don't see that in many clinical trials. So this is the updated and final PFS outcomes from the KarMMa-3 study. And you can see that this is ide-cel in patients who had 2 to 4 prior lines of therapy. So there is a big difference between patients who had 2 lines of therapy and patients who had 4 lines of therapy. And if you look at the median PFS in the standard regimen cohort, it's only 4.4 months. So I think that tells you what patient population we're dealing with, but you can see that ide-cel significantly improved the median PFS in patients who had 2 to 4 prior lines of therapy from 4.4 to 13.8 months. And the risk of death or progression was reduced by 51%. We saw significantly higher rates of CR and a deepening of response. And that continues with longer follow-up. So how do we choose a bridging regimen? This is the KarMMa-3 study that showed us that dara-pom-dex and carfilzomib-dex were the most effective in terms of bridging our patients. And these show response rates that were higher, deep remissions, debulking of disease, and better outcomes with the CAR T-cell. And you can see that median time without therapy within the first 60 days after CAR T-cell infusion was 26 days with ide-cel and 6 days with standard regimens. This is patients who received ide-cel and who never received a transplant. High-risk patients who relapsed early. This is the cohort 2B of the KarMMa-2 study. So these are patients who are very poor, very high risk, progressed less than 18 months from initiation of therapy, and received single ide-cel infusion. And you can see that at 2 years, 63.3% are progression-free. And this is not what we would expect with a functionally high-risk population. So clearly, using ide-cel earlier in the line of therapy, before the disease is becoming refractory, before the immune system becomes depleted, shows much more favorable and durable response. Cohort D of the CARTITUDE-2 study looked at similar patients. So here we're looking at patients who were newly diagnosed and achieved a suboptimal response after an auto transplant, so less than a CR. There's a small number of patients in this analysis. This is going to be presented here as an oral abstract on Monday. And you can see that 17 patients received cilta-cel right after auto as consolidation almost. Most of them did go on to lenalidomide maintenance, but not all of them. Overall response rate, 94%. Now, this is a population where it's very difficult to use ORR in this setting because they all had an auto transplant. So it's hard to know what the transplant did, what the T cells did. But what we're going to look for is durability, median PFS. And you see median DOR was not reached. And here, PFS and OS rates at 18 months were 94%. So certainly promising. We still need longer-term follow-up to know exactly what the role of the CAR T-cell is in this setting. But I think it's important to think about cilta-cel in this patient population who has suboptimal response to a transplant, high-risk patients. So now we'll talk a little bit about safety and planning with CAR T and get into some of the real-world data. So what is the safety profile of CAR T cells when you move it up in earlier lines of therapy? And here we have the CARTITUDE-4 study, which shows us that we do see hematologic toxicity, which is expected. Neutropenia, 94% of patients. Thrombocytopenia, most are grade 1 and 2. And what we do need to pay close attention to is infectious risk. And if you look at infections compared to standard of care, it does appear higher, 62% versus 27%. Oh, I'm sorry, that's grade 3. So grade 3 was 27%, and grade 3 in the standard of care was 24.5%, so not significantly higher. I think that with CAR T cells, we do see some increased risk of infections in the short term, but then after a certain amount of time with longer follow-up, you may see less infections compared to standard of care, chronic chemotherapy, where you're continuing to deplete the immunoglobulins and the B cells. The other side effect that we have to pay attention to is CRS, which occurred in 76% of patients. 1.1% was grade 3 or 4. We've now learned how to manage CRS. And neurotoxicity occurred in 20%. Only 2.8% were grade 3 or 4. And there were a small percentage, one patient did develop neurocognitive issues, and this was a much lower percentage than we saw in the later line of therapy using the same cilta-cel. In terms of ide-cel, I would say very similar side effect profile, hematologic toxicities, infections, and neurologic events. Very rare for it to be grade 3 or 4, and compared to standard care, we see similar amounts of infection and cytopenias as well. So some take-home points for delivery of CAR T cells. Refer to the certified appropriate facility in order for patients to have cells apheresed and start the process early. Once they've had at least one line of therapy is a good time to start the process, and once they've achieved a response to their current treatment. Earlier use is supported by both CARTITUDE-4 for cilta-cel and KarMMa-3 for ide-cel. We know that it has good overall response rates and durable remissions. Avoid prophylactic DEX or corticosteroids prior to lymphophoresis. Also, alkylators can interfere with lymphophoresis. And patients should have adequate bridging therapy and be aware of cytokine release syndrome. ICANS need to have aggressive management, proactive management, including tocilizumab, the anti-IL-6 monoclonal antibody, and dexamethasone in case there's neurologic toxicity. And infection is a very serious side effect. We have to make sure patients are receiving IVIG on a monthly basis if they're hypogammaglobulinemic, antibacterial prophylaxis, antiviral prophylaxis, PJP prophylaxis for patients who have CD4 counts less than 200, and in some cases, antifungal prophylaxis. There are new guidelines that were just presented in terms of interventions for infection prevention in patients who receive CAR T cells or bispecific antibodies. I think the important thing is prevention. Immunization of these patients is essential. Influenza, COVID-19, hepatitis B if they have a positive antibody and antigen. Fungal prophylaxis in patients who are very heavily pretreated or on chronic steroids, and PJP prophylaxis. And the other thing is any symptom that could be a sign of infection has to be evaluated fully and treated early. The real-world data confirms the efficacy of KarMMa, of ide-cel, in terms of both PFS and OS, and these are patients who would not have met clinical trial eligibility and still did very well. And same thing with cilta-cel. We do see impressive real-world data when we look at patients who would not have been eligible for clinical trial. They still did very well, with 12-month PFS of 67% and 12-month OS of almost 80%. So with that, we will move on to
Absolutely.
your-
Thank you so much, Noah, for
Yeah.
that presentation. And now Jonathan's going to take us through BCMA bispecific antibody therapy.
Okay, thank you both very much. All right, here's our patient. Max is a 78-year-old gentleman with triple-class refractory relapsed myeloma. He has high-risk disease with 1q amplification, deletion 17, and a performance status of 2. He's heavily pretreated. He had first-line therapy with RVD, auto transplant, and then lenalidomide maintenance. Second-line therapy was daratumumab, pomalidomide, dexamethasone. Only achieved a PR and had what I consider to be a relatively short duration of his response at 11 months. And so as soon as we see a patient, second-line therapy, who only has less than a year of progression-free survival, we really know what's going to happen next. And at this point, we have carfilzomib combinations, combination carfilzomib dex, carfilzomib cyclophosphamide dex, carfilzomib selinexor dex are all options. This is a very common option. He again achieves a PR, but unfortunately a very short duration of this next response. Also 4.5 months. At this point, we're very worried. We go back to the drawing board, want to use selinexor in this situation, look through the options, and choose selinexor, PomDex, and a very brief response. So, in my mind, I know what I would do for this patient, but I'll work this way. Noah, what do you think?
I think this is a patient, you don't have time to start the apheresis process. You need to treat and reduce disease burden immediately. This is a high-risk patient. Clearly, you're getting less and less out of every therapy. This is a perfect bispecific T-cell engager candidate.
Pete?
I would agree 100%. The challenge here, too, is, if you decide to go the CAR T route, what the heck are you going to use to control the disease before that apheresis slot is obtained? And how are you going to control the disease during the manufacturing process? It's very hard. And taking a 78-year-old individual with a large burden of disease going into the CAR T-cell infusion is very difficult. You've heard others talking about this already. The higher the burden of the disease, the harder it is, the harder the CRS, the harder the neurotoxicity, the harder the cytopenias. So definitely a bispecific antibody in this patient.
Yeah, I totally agree. I think before bispecifics, we really did not have a lot of options for this gentleman. We can talk about best practices for preventing infections, and we'll go through this, and step-up dosing for bispecifics. I'm interested in your practice. Are you doing the FDA label says the step-up dose has to be in the hospital? Are you guys doing it in the hospital, or have you found a way to do outpatient?
We are doing it in the hospital. We shorten the duration of stay. We dose, we have a very low threshold for tocilizumab to reduce risk of CRS, and then we dose each step-up dose 48 hours apart.
Yep, perfect. Pete?
We have a hospital-at-home program that we are partnering with to monitor the patients on the days that they're not getting their step-up dosing. So they'll see us in the clinic, for their step-up dosing, and they've got, 24/7 monitoring of their vital signs, et cetera. They've got an iPad with access to a nurse 24/7. They have somebody coming into their home or their lodging if they're from far away, on a daily basis until they're through the ramp-up period.
Great. So we have a 5 days a week. We have a 24-hour oncology specific, what we call intermediate care center, urgent care center. And so all the patients have the direct line to that. We give them education, and we'll have them come in for any symptoms. So I think everybody's trying to develop these programs. The shortening the duration of the hospitalization, I think, is really key also. Because there are still some patients that we do hospitalize, high disease burden, maybe don't have the support at home, and all of those types of things.
Absolutely.
So this gentleman, as we all agree, does not have time. We don't have the next line of therapy to control the disease for CAR T-cell. A great candidate for treatment next week, which is the off-the-shelf bispecific. And again, really important to have a comprehensive toxicity management plan for CRS, the neurologic toxicity, and infection prophylaxis, which we will go over. So what do we have for these late-line therapies? Those who've had 4 prior lines of therapy, including anti-CD38 monoclonal antibody, PIs, and IMiDs. We still have the CAR T-cell therapy, but we all agreed that that's not appropriate this time. And we have 3 approved bispecific. I'm going to focus on the BCMA bispecifics, elranatamab, as well as teclistamab. And I think Pete later on is going to talk a little bit about both talquetamab, the GPRC5D bispecific, as well as investigational bispecific antibodies. The way I explain to my patients, the bispecific antibodies, they grab the T cell on one hand and the myeloma cell targeting BCMA, activates the T cell, shrinks the immunologic synapse. These activated T cells then kill the BCMA positive plasma cells. So this is the data about teclistamab. Teclistamab was the first bispecific approved in myeloma. It was the Majestic trials, and we have an overall response rate of 63%, and that's in patients who had no prior BCMA, a little bit lower in patients who had prior BCMA, and responses deepen over time. But if you look at the primary data, the 63%, the vast majority of patients who respond to bispecific antibodies have a deep response. So of the 63%, it was 59%, the vast majority had a VGPR, and it was 45% of the patients had CR. So again, if one responds to bispecific, it's very likely to be a deep response. And why is that important? If you look at those, if you look at the median progression-free survival overall is 11 months. But again, remember, 37% of the patients didn't respond. Those patients who had a CR, you see significant improvement in their progression-free survival, which then subsequently translated to that improvement in overall survival. And I think, so this is follow-up data, and I think this is really, I think the most important thing about the teclistamab data is that, again, in the follow-up, longer follow-up, 63%, a little bit higher achieved CR. The duration of response for these 63% is 2 years. So, again, these are a really sick patient population who had, again, these are the prior durations of response have been 11 months, 4 months, 2 months, and we would predict if this patient was fortunate enough to be in essentially 2/3 of patients who responds, a predicted duration of response of 24 months. And again, we have, if you look at the overall patient population, median progression-free and overall survival of 11.4 and 22 months respectively. Real-world experience. Again, you see the overall response rates are very similar. CR rates remain similar. Where you see a difference is in the median progression-free survival. Median progression-free survival is about half of what we saw with in the real world than what we see in the original Majestic study. And I think in a large part, and I'll show this data later, this can be explained by a lot of prior BCMA use. Prior BCMA use only modestly impacts response, but it significantly impacts duration of response. And so part of what we're going to do as investigators and in the myeloma field is really figure out how to sequence these medications. The ELRA data in the magnetism studies had very similar outcomes. Again, this was a triple class refractory, 90% of the patients were triple class refractory, median prior lines of therapy is 5, overall response rate of 61%. I consider 61% and 63% essentially the same, and you'll notice very similarly that the majority of patients who respond to ELRA have a deep response, VGPR or CR, and of those patients who had MRD tested at least at 10 to the minus 5, over 90% of the patients were MRD negative. And what we see here with a relatively short follow-up is really both, again, we're seeing the same thing, that really impressive duration of response. And at 18 months, the duration of response is almost 69%. So very impressive. And here we see a median progression-free survival of 17 months. I think the caveat about this data, and we're really looking forward to updated data, but the caveat about this data is that it is less mature than what we saw with the teclistamab data. But again, that duration of response, in my mind, is what is probably the most impressive data about these medications. So, what about step-up dosing and safety issues? So the strategies for step-up dosing are different between teclistamab and or TEC and ELRA. That's how we colloquially know them. And so it was originally done as day 1, 4, and 7, but as Noah outlined, within the guidelines of in the package insert, you can really do it after 48 hours and don't have to wait those 72 hours. And you'll see here the first dose is extremely low. It's a 25th of the standard dose, so it's a fifth of the next step-up dose, and then the full dose is given, and then it's subsequently given weekly, and then every other week from there on. There's emerging data about going to monthly at 6 months, and we have started doing that based on toxicity data. ELRA has 2 step-up doses. Both of the step-up doses are much closer to the full dose, and again can get the full step-up dosing in a matter of 3 to 5 days. And then again, weekly, followed by every other week. And in here, there's no monthly outlined, but again, there's emerging institutional data and data that suggests monthly is very appropriate in responding patients later on in their course. What about toxicity? Very important. Infections are really important. And again, it was very nicely outlined earlier that BCMA is not a myeloma target. BCMA is a plasma cell target. And these drugs are really potent killers of plasma cells, both normal plasma cells and myeloma plasma cells. And so these patients have profound hypogammaglobulinemia, and infection is common in both ELRA and TEC. And in fact, serious infections, grade 3, 4 infections are common. CRS happens in 60 to 70% of the patients. Serious CRS is rare, and the vast majority of CRS happens in that first week. ICANS happens with bispecifics. It's rare in the 3 to 5% range with both drugs. Serious ICANS can occur, but that's extremely rare. Mm-hmm. What about thinking about prophylactic tocilizumab? There is a presentation here looking in the MajesTEC patient population that with the use of a single dose of prophylactic tocilizumab prior to dosing decreases CRS from 72% to 26%. We have instituted this at our institution, also early adopters based on safety data, and also very similarly have decreased, this data is exactly the same, have decreased our CRS rate from 73% to 26%. So, so that's another reason why we're able to move this as an outpatient, because we have so much lower CRS rate. Really critical in an effort led by Dr. Rodriguez Otero for the International Myeloma Working Group, has recently published guidelines. Really critical that these guidelines are followed. Again, very similar to CAR T-cell, PJP prophylaxis. Hopefully the patient can tolerate Bactrim. Everybody needs viral prophylaxis for HSV and varicella reactivation, as well as IVIG. Early implementation of IVIG is critical. I think in the studies we didn't appreciate that, and we lost a fair number of patients to COVID and similar infections. Now with regular use of early IVIG, we're able to really cut down on serious and life-threatening infections. Again, I'll just go, I touched on this briefly. Both Majestic and Magnetism have looked at their prior BCMA use and asked the question, what are the outcomes with BCMA bispecifics, whether it's teclistamab or elra? And what they showed is a modest decrease in response rate. Still, if the patient responds, most of the responses are deep responses. Maybe the proportion of a smaller proportion of CRs. And so with prior BCMA, whether it's ADC or CAR T-cell, there is slightly lower response, but again, we see, more importantly, lower overall progression-free survival. So BCMA bispecific antibodies are potent medications that offer efficacy in patients with relapsed refractory myeloma who historically had few, if any, treatment options available. They are associated with unique toxicity, similar to what we see with CAR T-cell with CRS and neurologic toxicities. There are new IMWG guidelines that are out and published. And really, when we're thinking about the future, we're looking at optimal dosing strategies and optimal sequencing approaches. And thank you for your attention, and I will hand it back to our leader. So thank you.
All right, so I'm going to talk about emerging bispecifics with new mechanisms of action. So we're going to start with another case. This is a 78-year-old patient with triple-class refractory relapsed myeloma. They have biallelic deletion of 17p. You knock out 2 TP53s, that's quite bad. Their performance status is 2. They got RVD, transplant, and len maintenance in first line, Dara-Pom-Dex in second line, KCD in third line. This sounds kind of familiar. Selinexor Pom-Dex in fourth line. And as you can see, the durability of their remissions is shortening with each line of therapy. They're referred for CAR T-cell therapy and receive it, and then they progress after 1 year. So this patient has had a 1-year response to BCMA-directed CAR T-cell therapy. So with that, how to choose between BCMA versus GPRC5D. So Noah, I'll start with you. Would you go with a BCMA-directed therapy in this patient or GPRC5D?
So after 1 year, there is evidence that you do have BCMA expression reemerge from myeloma cells, so it would be reasonable to use a BCMA bispecific T-cell engager. I think you could save that one for later. You could absolutely use your GPRC5D because this is a patient who is relapsing right from a BCMA CAR T. And I think the real question is, which toxicities do you not want? So as we go into talquetamab, we'll learn about some of the GPRC5D toxicities, but they do tend to be dysgeusia, nail changes, skin changes, and they can be, very annoying to the patient, such that some may want to hold therapy or delay therapy.
Jonathan, BCMA versus GPRC5D.
I mean, this is a daily, every week I have to have a conversation with a patient similar to this, and I'm really going with the GPRC5D here. Having looked at all of the data about BCMA followed by BCMA, I just don't think we're going to get out of it what we want. And so, even though there's the toxicity that is bothersome to say the least, I think GPRC5D here is the right thing to do.
Yeah, I would agree. And the durability of the response is going to go into the decision-making process, but 12 months is not that long. So certainly I think going with a different target makes a lot of sense. Does anybody want to comment on emerging bispecifics that may play a role in relapse refractory myeloma? Noah?
Yeah, so certainly we're looking at novel targets, FCRH5, and then we're looking at different ways of administering bispecific T-cell engagers, whether it is fixed duration in earlier lines of therapy, in combination therapies, in different dosing schedules. There's going to be some data presented with the AbbVie bispecific BCMA T-cell engager looking at once monthly dosing, not requiring step-up. So I think there's really much more effective and more convenient ways of administering these agents and with less toxicity.
Jonathan?
Yeah, I would just reiterate, I'm very interested in the data behind the once a month, no step-up dosing. That's very, very attractive. And hopefully we see similar efficacy with that much more convenient strategy.
Yep, no, absolutely. So just to let folks know, we've got several BCMA bispecific antibodies that are in development and have launched phase 3 studies. So there's Regeneron's linvoseltamab, and then there's AbbVie's ABBV-383 that Noah referred to. So it'll be very interesting to see those data emerge over the course of time. And then another very interesting emerging bispecific that I'll talk about shortly is cevostamab, which targets the FCRH5. As was discussed, and there's actually trispecific antibodies in development. So for example, trispecific antibodies that target both BCMA and GPRC5D. So as far as recommendations, with earlier line use of BCMA CAR-T, this patient type is going to become more frequent moving forward. As Jonathan mentioned, he has this conversation with his patients in clinic weekly now. Standard evaluations of BCMA expression should be employed to see if another BCMA targeting strategy could be considered. There's a company called Phenopath where you can do immunohistochemical staining for BCMA. A lot of centers are looking at flow cytometry-based assays for BCMA expression. But we do know that BCMA loss of expression is at least one mode of resistance to this class of agents. And if you have no BCMA expression, it makes absolutely no sense to expose a patient to the toxicities of a BCMA bispecific or CAR-T when they have no chance of responding. Consensus is needed on T-cell fitness assays to determine whether a T-cell engager approach is feasible. A lot of interest in better understanding T-cell fitness and how that plays into efficacy and durability of response. And then this whole sequencing question, which we'll talk more about in a bit. So these are the NCCN guidelines for bispecific antibodies in late relapse. Jonathan showed this earlier, and we're just highlighting talquetamab, which is the GPRC5D bispecific antibody that is FDA approved in these late relapse patients who've had 4 or more prior lines of therapy. So just like the BCMA bispecific antibodies, talquetamab grabs onto a T cell through CD3, which is associated with the T cell receptor, but it binds to the myeloma cell through GPRC5D, essentially forming an immune synapse between the two, leading to activation of the T cell against the myeloma. One of the things that's kind of interesting about GPRC5D is that it does seem to be expressed at higher levels in malignant plasma cells relative to normal plasma cells, which may explain some of the less hypogammaglobulinemia that we see with this particular agent compared to BCMA bispecifics. There's also no expression of GPRC5D in mature B-cell subsets, which is not the case with BCMA-directed therapy, where you do knock out some of those mature B cells as well, which may also explain the differential in acquired hypogammaglobulinemia as well as infection. So talquetamab was approved based on the Monumental 1 study. This is a study that was done in heavily pre-treated patients. The vast majority of them, were triple-class refractory. And as you can see here, the overall response rate, whether you were looking at weekly versus every other week dosing, ranged for anywhere from 71 to 74%. For those that were naive to prior T-cell redirecting therapies. But interestingly, they had a cohort of 51 patients with prior T-cell redirecting therapy, and there the overall response rate was an impressive 67%, and actually the durability of those responses was actually quite good too, which we don't show here. So as far as real-world evidence on talquetamab in patients exposed to prior T-cell engagers. So this is a chart review of patients with relapsed refractory myeloma who had previously received T-cell redirecting therapy, now receiving talquetamab. The caveat here is it's only 21 patients, very heavily pretreated with 7 median prior lines of therapy, 85% of patients triple-class refractory, 3/4 of the patients had received prior BCMA-directed CAR T-cell therapy, and 86% did not meet inclusion criteria for the Monumental 1 study. Despite this, in this patient population, the overall response rate was 71.4%, and the complete response rate was close to 30%, very comparable to those results seen with the Monumental 1 study, but longer follow-up is needed to see whether that durability of response is there as well. This will be the subject of a poster presentation that we'll see Monday morning. So as far as talquetamab dosing and principles, I'm going to focus on the every other week dosing, which I think most of us are probably doing for patient convenience purposes. So with every other week dosing, you're ultimately going to get to 0.8 milligrams per kilogram, and there are 3 step-up doses before you get to that first full dose. So the ramp-up period is actually 4 doses over 10 days. But to Jonathan's point earlier, you can actually shorten the time interval between administration of those ramp-up doses if the patient is otherwise doing well. So as far as safety issues, so as was alluded to earlier, because GPRC5D is expressed in hair follicles, we see skin-related changes. So we see a rash, we see dry skin, we see pruritus, we see nail-related changes, brittle nails. Occasionally, they can even fall off. This occurs in about 70% of patients. I always tell patients if you're going to be on this long enough, you're going to get those side effects. But topical corticosteroids are actually quite effective for the rash. The nail issues, which are more cosmetic than anything else, don't really respond to topical steroids in that particular case. We alluded to the dysgeusia that patients have, which can be quite challenging for them. They'll sometimes get dry mouth. They'll have some dysphagia as well. And if these side effects are not well managed, it can even lead to weight loss. So you really have to be careful with this. And there's a lot of interest in developing strategies to mitigate this particular toxicity. But right now, dose holds and dose reductions seem to be the best way to do that. And with less frequent dosing, it does seem to get better as well. There's the cytokine release syndrome, which is quite common, but just like with the BCMA bispecifics, the vast majority of it is grade 1, some of it grade 2, and it's very unusual to have a grade 3 or 4 CRS event with this particular bispecific antibody. And as I mentioned before, the infection signal seems to be a bit better with this than the BCMA bispecific, so the total infection risk ranges from 30 to 50%, and the rates of grade 3 and higher infections are also lower. So I mentioned this before, so linvoseltamab is the BCMA bispecific antibody that's being developed currently by Regeneron. Very nice data with this particular agent as monotherapy in heavily pretreated patients with response rate of 70%, ABBV 383. is the BCMA bispecific antibody being developed by AbbVie. And some of the unique things about this is that it, one, has two BCMA binding domains. The CD3 binding domain for the T cells is actually a low affinity binding domain, and we think that that's why you're able to use full dose from day one, because you can mitigate some of the CRS with that low affinity CD3 binding. And then there's the silenced FC portion of the antibody, which extends the half-life and allows dosing once every 3 to 4 weeks, depending on what study that you're looking at. Both of these companies have launched registrational studies for these products in earlier relapse patients. So linvoseltamab, as I alluded to before, in the linker MM1 study had an overall response rate of 70%. The median progression-free survival with relatively short follow-up had not been reached yet. And again, the phase 3 study is comparing linvoseltamab to elotuzumab with Pomdex in patients with 1 to 3 prior lines of therapy. ABBV 383 has an overall response rate that ranges in the 60s to 65% range, like we see with elranatamab and teclistamab. And these responses are seen at 40 milligrams every 3 weeks, including 60 milligrams every 3 and 4 weeks. And it's the 60 milligram every 4-week dosing that's being moved forward to phase 3 studies. And they're doing a similarly designed study in earlier relapse of 383 versus investigator's choice. So what other targets do we have in multiple myeloma? So cevostamab, as I mentioned before, this is an T-cell, this is a bispecific antibody that targets FcRH5. So this is a relatively plasma cell specific target on the surface of myeloma cells. It's also expressed on normal B cells, plasma cells. It's also expressed on certain subsets of mature B cells like BCMA is. So that infection risk is something that we have to be mindful of. But unlike talquetamab, it doesn't have expression on non-hematopoietic tissues. So this is the initial data with cevostamab in heavily pretreated patients, so 161 patients, 6 median prior lines of therapy. Most patients had prior CD38 antibody therapy, but importantly, a third of the patients had had prior BCMA directed therapy, including CAR-T and antibody drug conjugates, as well as prior bispecific antibody therapy, and the vast majority were triple-class refractory. And what you can see here is at the 132 to 198 milligram dose levels, which includes 60 patients, the overall response rate was 56.7%. And just like with the BCMA targeted therapies and GPRC5D bispecific antibodies, the majority of the responses are deep. So to summarize, the addition of CD38 antibodies to triplets during induction enhances response, depth, MRD negativity rates, and response durability in transplant-eligible patients. It benefits standard risk and high-risk patients based on the Perseus data. Adding a CD38 antibody to doublets or triplets is feasible in many transplant-ineligible patients as well. The emerging role of CD38 antibodies and IMiDs as part of maintenance and therapy continuation is actively being studied, and BCMA-targeted CAR-Ts are now available in patients in first and second relapse and showing comparable safety and efficacy profiles as seen in patients that are more heavily pretreated, and I would argue actually more favorable efficacy safety profiles in that group of patients. Antibacterial and antiviral prophylaxis is key to minimizing infectious risk with these agents, as we've talked about before. Bispecific T-cell engagers directed against BCMA and GPRC5D are now approved, with others coming. They require similar prophylactic strategies as for CAR T-cell therapies and for step-up dosing. And optimal sequencing of these therapies, mechanisms of resistance, and combination strategies, all of that is under investigation, and we'll learn more in the months and years ahead. So with that, we're going to go on to the audience question and answer session. So I think what I'm going to do is start off in the newly diagnosed space, and I'm going to go back to a question, that I asked Noah previously, but I'm going to ask Jonathan the question. For high-risk patients with newly diagnosed myeloma, CD38 antibody with RVD or KRD?
So, you're trading toxicity. I don't think there's enough data. There's small amounts of data. There's a lot of belief that one proteasome inhibitor is better than another proteasome inhibitor in a high-risk setting, and I'm just not convinced of that. And so what you're doing is you're trading toxicity. Do you accept a 50% neuropathy rate, rare, that's very bothersome to say the least, or do you accept a 3 to 5% significant cardiac toxicity rate? And I think that's really the whole decision. Bortezomib is easier to give. It's subcutaneous. A lot of people switch from twice weekly to once weekly. Carfilzomib is intravenous. It's probably harder to give. I think outside of neuropathy, it probably has more side effects. So I think it's really, in my mind, what you're really trading is sort of convenience / toxicity. And I'm yet to be convinced on the efficacy side that you're trading anything, especially in the context of a 4-drug comprehensive treatment program.
Yeah, no, I mean, I think that the quadruplets in general are quite powerful. You've got single-arm phase 2 data that the KRD CD38 antibody platforms are really showing remarkable MRD results, but I think that the Perseus data and the MRD data that is starting to emerge from that look really quite good as well. So it's a win-win situation for patients, and I agree, discussing the potential toxicities of the different proteasome inhibitors is important.
And I think in my mind, you showed, and I don't know if you showed the Ischia data earlier. I call it IKEA because I can never get it right. But the most impressive thing, that's a lot of treatment. That's what is it? Almost 2 years of really intensive therapy. That's hard to do for a standard risk patient. But the patients with 2 cytogenetic abnormalities, that's the most impressive data I've ever seen for patients with 2 cytogenetic abnormalities. And I don't know if it was because of the comprehensive nature of it or because they used carfilzomib instead of bortezomib. I don't know. But that was really, I think, so we have switched to an Ischia-like regimen for our 2 cytogenetic abnormality patients.
Yeah, and the GMMG concept study is similar. They took a very high-risk patient population. It was a single-arm phase 2 study. They had a transplant-eligible and ineligible pathway. And here again, it was isatuximab with KRD-based platform, but they treated patients longitudinally with multiple drugs and really quite impressive results in many patients who had 2 or more high-risk cytogenetic abnormalities. So Noah, a question that came up, would we ever, we talked about, using a CD38 based platform for bridging our patient in early relapse who's going to get CAR T-cell therapy. Would you ever avoid using a CD38 antibody as part of upfront therapy, since you'll lose that as a strong bridging regimen when using CAR T-cell therapy in the early relapse space?
Thank you for asking that question. So I think there's no doubt about it that the addition of a monoclonal antibody increases your MRD negativity rate, increases your progression-free survival, and certainly, in transplant ineligible and ineligible patients, we've proved in both phase 2 and in phase 3 studies that they are improving depth of response and progression-free survival. My question is, what about later? What happens? PFS is not the best endpoint. It's the best endpoint that we have. And MRD negativity is not the best endpoint. It is the best endpoint that we have because we can't wait 10 or 20 years for survival data to make decisions. But we've seen with Cassiopeia, which included DARA either at induction or DARA at maintenance, the outcomes were the same in patients who it didn't matter when you got the DARA. That's the bottom line. If you got it in induction or you got it in maintenance, didn't matter. The outcomes were the same as long as you got it. And my question is, especially with these bispecific T-cell engagers that we're going to have more and more of them, we're depleting the immune system. CAR T-cell, we need functional T-cells. What are we doing for later relapses when we're giving everybody monoclonal antibodies at first relapse? And these patients are not going to be monoclonal antibody refractory, just exposed, but still, will they have effective immune systems later down the line? And I think there is some small data sets that are showing that response rates are lower in first relapse for patients who have had upfront monoclonal antibodies. Very small data. So I think, we have to do what's best for our patients right now with the information that we have, but we need to keep in mind, we don't know what the future will hold for these monoclonal antibody exposed patients.
Yeah, no, I would agree with that. A similar question, Jonathan. You have a patient who starts on VRd therapy and is responding, but it's a sluggish response. Could you just add the CD38 antibody for those patients with suboptimal responses to the triplet?
I would say yes. I would have done it in the first place, so why not? I think that's been, in all seriousness, if I have a patient that's referred to me for transplant and they've had RVD or KRD and they've achieved a major response, we're just going to go with transplant. They've responded. But if I've have a patient who's had RVD or KRD and they see me after 2 or 3 cycles and they haven't had a major response or they haven't responded at all, I'm certainly going to add the monoclonal antibody at that time. So the only time I wouldn't is if somebody had a major response without it.
Yeah, very good.
But so that, a similar study is being looked at by ECOG. It's not the exact same study, but the question is can you treat with a triplet for a certain amount of time, and then add for those patients who fail to achieve, however you define major response, MRD negativity or CR, or however you define it.
Yep, absolutely. So Noah, I think I know your answer, but I'm going to ask it anyways. Would you ever defer transplant in cases where you've achieved an MRD negative response after your CD38-based induction therapy? Could you go directly to maintenance and bypass transplant in a transplant-eligible patient?
It depends what your goal is, right? So, and it depends who the patient is. My answer to that in general is don't give up transplant, because it's one of the best treatments that we have in a disease that we're not curing, even in standard risk patients. Use it, because every treatment is additive. And if you collect stem cells and defer your transplant, you're going to have a much shorter duration of remission if you use that transplant at first relapse. And so, A, you may not get there because treatment-related toxicity, disease-related toxicity, patients defer it. And B, the risk of mortality is higher when you do it with a much, an older or a sicker patient. And the PFS is going to be much shorter. So if you're going to do the transplant, do it in the upfront setting, even if you achieve MRD negativity. And the other point is, you always have to think about what's the alternative to transplant. The alternative to transplant is not nothing, observation, it's continued chemotherapy. And these are patients who are going to continue on steroids, continue on monoclonal antibodies, IMiDs, and develop further and further immunosuppression with time and disease and treatment-related toxicities.
Yeah, the question sort of asks, can you do induction, get a great response, and then go right to maintenance? And I think there's enough data that says, and I agree in both in principle and practice about early transplant. But there's enough doctors out there, myeloma doctors, who really routinely delay transplant. But if we were going to delay transplant, you don't skip out on the other 4 or 8 cycles. Determination did a total of 8 cycles of RVD. Forte did a total of 8 cycles of KRD. If you go right to maintenance, 100% the progression-free survival is going to be shortened. at least as a population, not any, and so you really need to go that 8 or 12 cycles. And so it's not just stopping or just going to maintenance.
Yep, no, I would completely agree. Jonathan, we've talked a little bit about MRD assessment. Are you doing MRD testing in your patients? How are you using MRD in your practice?
So we are testing MRD. There is, you mentioned earlier, there's a lot of, there's hints that we can use MRD, not for escalation, but for discontinuation. And I think there are, there's some data sets that suggest after transplant, patients MRD negative, there's no harm in discontinuing lenalidomide maintenance. We have an approach, and we hopefully will publish or present at a meeting this year our experience with about 50 patients who are MRD negative to the -6 at year 2 and at year 3, and then discontinuing lenalidomide. I haven't formally assessed all of the patients, but so far it looks like it's a very reasonable idea. And the reason I think it's probably okay, because if you look at the meta-analysis of len maintenance that led to the 10% overall survival advantage, the median time of len use was 2 years. So there must be a patient population that doesn't need len forever.
And the pivotal study, randomized study that will answer this question most definitively is the SWOG study, which is taking patients who are 2 years into their maintenance therapy, either with len monotherapy or dara-len, and if they're MRD negative at 10 to the -6, not 10 to the -5,
right,
they're randomly assigned to continue their maintenance therapy that they started or stop it. And we'll see if those patients that stop do as well as the patients who continue and enjoy better quality of life off therapy.
Yeah, I mean, I'll just mention this quality of life. If you ask, a lot of patients on len maintenance have really life-impacting diarrhea. And I've stopped asking how many times a day you go. I say to them, do you plan your entire day around where the bathroom is? And if they say yes, I consider that a grade 3 toxicity, and they should come off that treatment.
Yeah.
They all get that.
They all get that.
They all get that. It's just a matter of when.
Right.
Yeah. I'm going to pivot now to the T-cell engagers, and this is a question that's often asked. I think as we get more data and longer follow-up, we'll probably be able to answer this better. But Noah, we have BCMA-directed CAR T-cell therapy. We have BCMA bispecifics. If you're going to use bispecifics first and CAR T-cell later, or vice versa, how much time do you want in between those strategies before you challenge them with the other?
As much as possible, but by the time you're in that relapse refractory setting, you don't have that luxury in the majority of patients. So, there's really no established time between BCMA therapies. There's some evidence that you need at least 1 year between BCMA therapies to have an effect. But my preference in sequencing is BCMA CAR T, if possible, followed by a GPRC5D bispecific T-cell engager, and then you can always go back to that BCMA bispecific T-cell engager.
I agree.
Jonathan?
Yeah, I agree. That's my general approach. I think if I can use a CAR T, if I think the patient's going to be a CAR T candidate, I'm going to use a BCMA CAR T and then a GPRC5D later. If I don't think the patient's a CAR T candidate, I'm going to choose a BCMA bispecific. Primarily, again, this is trading off toxicity, which is all of the really bothersome skin, nail, oral toxicity, weight loss, versus the infections, which I think we've got a much better handle on now with the liberal use of IVIG.
Yeah, no, I agree. I think, as we start to use CAR T-cell therapy in earlier relapse, patients with better control of disease going into CAR T-cell therapy we're going to have a larger proportion of patients who have durable responses to CAR T-cell therapy. They're going to have more time removed from their CAR T-cell therapy. And I think that there's going to be an appetite for using BCMA bispecifics in that group of patients. We talked briefly before about testing for BCMA expression at the time of relapse, which I think is incredibly important if you're going to expose a patient to another BCMA targeted agent in the future. But I do think that there is, the ability to do a BCMA CAR T followed by BCMA bispecific. The data in the reverse order, to me, doesn't look as good. There's the CARD2 cohort of patients, who got a cilta-cel after BCMA-directed therapy, and the data were not nearly as strong as what we saw with the overall CARTITUDE-1 cohort, and similar experience, real-world experience from the ide-cel, from the U.S. CAR T-cell Consortium. So anyhow, talking about CAR T-cell therapy, Jonathan, someone asks, once you get removed from the specialized center, so you're, close to the specialized center for 30 days, then you go back to your local hematologist, oncologist. So what do they need to worry about as far as long-term toxicity issues?
Yeah, a great question. Particularly with cilta-cel, we do see the late neurologic toxicities that's not ICANS, the Parkinson's-like, and the cranial nerve issues, Bell's palsy, the cranial palsies. So those can happen in the 30 days to 6 month range. Need to continue IVIG for 6 months, continue pneumocystis prophylaxis for 6 months. For the most part, once a patient's out 6 months, there's really, there shouldn't, as long as the toxicities have resolved, there's really little, and you really don't need those intensive infection prophylaxis in the CAR T-cell population. And now you're looking out for relapse.
Yeah, I would just add pancytopenia can be prolonged, and sometimes in patients who started off with baseline low blood counts, they're going to you almost have to expect they're going to be transfusion dependent for quite some time. And sometimes the pancytopenia resolves and then the relapse occurs. So I wonder if there's some kind of T-cell phenomenon occurring on the peripheral cells.
Yeah, and that actually gets to another question here, about second autologous stem cell transplant, for those that have enough cells collected for more than one transplant, or do you just save them as a potential stem cell boost for prolonged pancytopenia after CAR T-cell therapy? And you guys can agree or disagree with me, but I think we have such an embarrassment of riches in the relapse space, that second autologous stem cell transplants are being used less and less over the course of time. And to Noah's point, particularly for patients that are heavily pretreated, bad marrow reserves, large burden of disease going into CAR T-cell therapy, they can have prolonged severe cytopenias, and a stem cell boost for those patients, 1 to 3 months after the CAR T-cell therapy can help reestablish counts and get them out of the trap of constant platelet red cell transfusions and growth factor support. And then the only other things as far as long-term toxicities to worry about for the local hematologist oncologist is the MDS-AML signal, especially for the more heavily pretreated patients, and the fact that they're going to need to treat those patients with IVIG on a monthly basis for anywhere from 1 to 2 years or so as the normal plasma cell pool recovers. So with that, I think we're going to go ahead and wrap things up. Thank you all so much for joining us on this rainy Chicago day, and enjoy the rest of your ASCO.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, HealthTree Foundation for Multiple Myeloma. This activity is supported through educational grants from Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, which are both Johnson & Johnson companies, and Sanofi. To access all materials for this activity, visit peerview.com/VRK860.